Hello everyone, welcome back. This is Professor Harkirat Bal. Today I'm bringing another very important and sensitive topic called substance-related and addictive disorders. This is going to be another long lecture, so I'm going to divide it into three parts. This is a part one of the series, and make sure you start off with this one, please. So let's dive in. We will talk about pathophysiology in depth in a few minutes. But before we do that, I think we all understand that what starts out as a fun to increase the dopamine, to get more pleasure, this activity quickly end up being a devastating disease, right? So before we really get into our lecture, I want to make a very important statement. I really want you to approach this topic from a disease perspective rather than thinking, well, it's their fault, they should just stop using that drug and they'll be fine. Well, that kind of thinking really adds stigma and it oversimplifies a complex health issue that we are going to talk about today. Now, to help reframe this, I want you to compare this with something like diabetes, let's say, and more specifically, we can say type 2 diabetes, right? We would never say to someone with diabetes, well, it's all in your head, just stop eating sugar and you will be fine. Instead, we do proper assessment, we treat, we provide support, and we understand their concerns without passing any judgment. So I really want you um, to think the same way when it comes to a client dealing with substance use disorder. We need to understand the pathophysiology behind it, just like eating sugar or drinking coffee or smoking cigarette. We actually increase dopamine, and dopamine is a very important neurotransmitter that gives us a pleasure, right? We know all that. So you can say that our brain is hijacked when we use these substances. So we really need to see this from a medical standpoint of view instead of adding more stigma. So with that mindset, let's explore the topic more deeply. Okay, so this is a more of a rhetorical question. I really don't need to know the answer, especially if it puts you in trouble, if you will. But I want you to think, what substance do you use to stay awake, or when you study, or just trying to have fun, or maybe when you have an important task? Well, if you drink a cup of tea or coffee, or smoke a cigarette, or perhaps drink a can of beer or a glass of wine, or take any other over-the-counter medications, etc., then you are really using the most commonly used substance here in the US. Now, chemical substance is really part of our lives. I think that's the point I'm trying to make here. And we don't really think that way, that we use the substance on a daily basis. But think about how many of us are actually dependent on our morning drink, tea, coffee, or some kind of energy drink, right? And if we don't get that in a timely manner, how does that really change our mood or behavior? Do we get tired, irritable? I don't want to talk to anybody until I get my morning tea or coffee, right? So we should not judge people. At the same time, please understand that just having a substance, let's say tea or coffee, caffeine, or even alcohol on a daily basis, does not mean that you're meeting the criteria for substance use disorder. You really need to meet the criteria and have a negative impact on the ADLs before we label someone that they have substance use disorder. So we'll talk more about the criteria about specific agents later on, but right now just understand that just having a substance use does not mean that is a substance use disorder. Okay, well, quick history lesson. Not that you will ever be tested on history, but I think it's so important to study history and learn from it. So, what do you think our ancestors used in the past? Well, it's really hard to trace the history of substance use, but we believe there probably has never been a time since the Bronze Age when humans have not had access to alcohol. Early humans made fermented liquor from fruits, rice, algae, and so forth. And tobacco had its origin, gosh, all the way back to maybe 7,000 years ago or so. And some research even claim that marijuana use began about 1,000 years ago or so. Now, coming to current issue, modern history, if you will, we have synthetic drugs now, right? Morphine or fentanyl, which is 100 times more potent than morphine, causing an opioid epidemic in our country right now. Well, talking about a history, let me give you another very interesting example of Coca-Cola. Well, Coca-Cola actually contained cocaine back in the days. In late 1800s, their original formula actually had extract from coca leaves, and it is estimated that about an 8-ounce of serving may have contained about 9 milligram of cocaine. So in those early formulation, they would advertise this as a stimulant tonic to boost your energy and relieve fatigue. And then, of course, with the better understanding of the overall impact of cocaine on our body, such as addiction and so forth, Coca-Cola removed the cocaine from their formula in 1903. So this is a very fascinating example, I think, of how societal perceptions and scientific understanding of a substance have changed over time. Okay, well, let's understand some definitions, some important terminology to really have a better understanding of substance use disorders. The first one on the list is drug use. What is a drug use? Well, it's when you take any type of a drug, either over-the-counter prescription medications or a medication from the parking lot, if you will, maybe a natural medication or synthetic, it doesn't really matter, and the route doesn't matter either. It could be topical, it could be sublingual, PO, suppository, IM injections, IV, and so forth. So when you take any drug, any substance, I should say, that has a potential to make any chemical changes inside your body is a drug use. Okay, very important concept is a tolerance. What is tolerance? I think it's, as a clinicians, it's so important to understand this so that we can differentiate dependency from tolerance, because this is a normal physiology, right? So I'll give you example in a minute, but the definition is when you see the need, when the patient tells you that they need to take more medication to get the same effect. So and if they don't increase the dosage or the frequency, then they do not get the same effect that they were getting not that long ago. So increase the dose of a substance to achieve the desired effect, or the effect is decreased when they use the same dosage. Okay, now the tolerance depends on individual. It's a highly individualized concept, if you will. And I'll give you an example. Let's say you have a client who's taking a drug. Let's give you an example of Norco as a pain management, because I think we understand this concept very well. Okay, so if the patient was taking a pain medication, let's say 5 milligram, 5-325, we can say. Okay, so if the patient was taking one tablet, PO by mouth, 3 times a day, maybe every 8 hours or so, PRN for pain. When they took one tab every 3 hours for acute pain, let's say status post a knee replacement or some kind of surgery, right? And they report that when pain is 8 out of 10, and when they take one pill, they feel better, and they report pain to be at 3, let's say. So that's a good goal here, right? Now, over time, let's say now they're reporting that when they take one pill, when they have a pain 8, after a few minutes, 45 minutes, 1 hour, their pain is not at 3. Maybe it's still at, let's say 5, or maybe more than that, 6, 7. And now they have to take 2 tabs, either 2 tabs, so they're increasing the dosage, or taking more frequently. Instead of every 8 hours TID, let's say, they're taking maybe every, I don't know, 6 hours or 4 times a day. So they're either increasing the dosage or the frequency to get the same effect. So from 8 to 3, they have to take 2 tabs, where before they only had to take 1 to get to 3. If they were to take 2, 3 weeks ago, a month ago, maybe their pain will go all the way back to 0, if they maybe they will be drowsy or some other symptoms, right? So the point I'm trying to make here is this is a normal physiology that people build tolerance, and one way to find out is if you see high blood level of substance with no evidence or little evidence of intoxication. So they're not giving you symptoms of intoxication, but the levels are high, so they're taking more medication. Perhaps they're building tolerance. Now, very quick example that I want to give you is using a different drug, just to make my point, is that we see with other medications such as diabetes or blood pressure. Remember, there's a time when the patient takes 15 units of Lantus, or I don't know, 5 milligram of some blood pressure medication, and we see a good result. But over time, a client may develop a tolerance, and now you need to increase the dose of insulin or blood pressure medication or some other, maybe depression medication and so forth. So please understand, this is normal. Do not all of a sudden judge people that they are addicted to medication or they're abusing that drug, because if we do not understand this concept and we are not transparent with this patient and getting more information, that means we are not addressing their underlying problem, which is that we are not managing their pain, and then we are forcing them to really contact their family or friend or go to the parking lot and get a medication, because somehow they're going to get that medication because they don't feel good, right? So we do not want to open that door where we are giving them an opportunity to take their medication illegally, when we can actually intervene and manage their pain more appropriately. Okay, so I think that's very, very important concept. Okay, so next important term is dependence. Well, dependence is actually difficult to define and difficult to even identify, to be honest with you, but there's a difference between tolerance and dependency. This is where you see behavior associated with inability to control use of drug. So people are not able to control their behavior. So you see irritable, agitation, aggressive type of behavior, but they're willing to do anything to get the drug. So, and I'll come back to it in a minute, but another term is abuse. Abuse is actually again, difficult to define, but we believe abuse is when a client continue to use that harmful substance in the setting of a maladaptive pattern. What do I mean by that? Well, they're not using it as to treat a pain, if you will. If it's acute pain, we know that's not abuse, right? You need to take medication. But if you're not in pain and you're using it as a maladaptive, you have stress in your life, and instead of working on the stress, you have a client who ended up using either let's say alcohol to numb your brain temporarily. To you feel better. We know that we feel better when we drink alcohol, right? At least temporarily, right? So there's overall impact of when you continue to use that substance for longer duration. There's a negative impact on the ADLs. There's issues at home, at work, school, and DSM talk about this. That's one of the criteria, that there has to be negative impact. Now I'll give you a quick example of a maladaptive pattern. Let's say you have issues at work, and you come home and you drink alcohol, so that it really helps you to go to bed and put a lid on those problems. And that's all it is literally putting a lid on it. You're not going to solve that problem by drinking alcohol, right? So, but if you do that once in a while and you're able to go back to work again and resolve those conflicts, then that's not abuse. But if you're using alcohol or any substance for that matter, and not able to resolve the conflict, and now you see overall impact, then that's a maladaptive. Now the healthy coping skill would have been you arrange a meeting with your supervisor, sit down with them, talk about those issues that's bothering you, come up with some options, and if you believe it's not getting better, it's not getting resolved, then the right way to handle this would be either follow the chain of command or give them a 2 weeks notice, right? It's not worth drinking alcohol every single day and damage your body and be unhappy at work. Give them 2 weeks notice and then walk out, and then go from there, right? And maybe it's not easy to quit a job, so I'm not minimizing their thought process, by the way, but you see a circle here, right? But anytime you keep using that as a maladaptive and there's a negative impact, then we believe then there's a potential a presentation of abuse here now. Okay, now please understand that abuse and dependency, these presentations, and they overlap, and it becomes very difficult as a clinician to distinguish one from another, and therefore DSM has really merged these terms together, abuse and dependency, and we really have a set diagnosis of a use disorder. That's what we use moving forward. So I'll give you an example of alcohol use disorder, and then you'll see that we have a generic term that we use, and it's a use disorder instead of a dependency or abuse. Okay, what is craving? Well, craving is a strong urge to use the substance during acute withdrawal. Ask if there has ever been a time when you had such a strong urge to use the drug that you could not think of anything else. If the answer is yes, most likely the client is craving for that substance. Okay, so another term on the list is addiction. Addiction is actually very difficult to define, and there's a lot of subjectivity to it. So the term is when you have a client with a difficulty to abstain from the substance. Please understand the term addiction has been removed from the DSM criteria because of its a potential negative connotation. That's where we add more stigma to mental health. We use a more neutral term called substance use disorder. So this is the term that I want you to use moving forward. This is how we should document a client with a substance use disorder. That's a generic term. And then once you identify what type of substance, then we'll say a client with alcohol use disorder or client with tobacco use disorder, or and so forth, right? Please understand, we are not going to use the term addiction or abuse. Those two terms add more stigma, and as a clinician, it is our responsibility to offer an environment where our clients, they feel comfortable enough to express their symptoms, their feelings, and we should listen to them instead of passing judgment, so that we give them a correct diagnosis, because we know that the correct treatment that a client receives depends on the correct diagnosis they receive. So moving forward, substance use disorder, not addiction, not abuse. Okay, next important term is intoxication, and this is when you have a client using too much of that substance, right? And you will have some symptoms based off of the agent they were using too much. Withdrawal is the opposite. This is when you have a client who was using a substance for a long time period, and now they're not using it, and then you see some behavioral changes or physiological changes, physical symptoms such as maybe blood pressure changes and heart rate and breathing pattern and so forth, and some other behavioral cognitive, like maybe a mental status change and so forth, right? This is when you have blood concentration of that substance is decreasing after a prolonged use of that substance. It doesn't happen if you took a medication for a day or so, like for acute pain, let's say. If somebody was taking narcotics, they're not going to go through, usually they do not go through withdrawal. But if somebody was using a substance for a long time, like a chronic use, and then all of a sudden they don't have access to it, or they stop taking it, then you will see the withdrawal. Now, moving forward, the rest of the lecture for any type of substance use will focus on three main things. Number one, we will talk about substance use disorder, and that's how the DSM is organized. And so remember, we don't use the term abuse or addiction. So the first thing is going to be use, some type of substance use, either alcohol, tobacco, opioids, and so forth. And then second, what happened when they take too much. So we'll talk about the intoxication. And number three is going to be the withdrawal, when you don't have enough agent substance in the blood. So these are the three things. Now, you don't have to go through intoxication or withdrawal to meet the criteria of use disorder, and we'll talk more about that, by the way, but this is going to be the format moving forward. Now, why is this important? Why are we talking about substance use disorder or intoxication? What happens when they take too much? Well, you can have a serious impairment, right? Serious consequences. For example, overall dysfunction at home, at work, problems in the family, not able to take responsibilities, traffic accidents, fighting, that aggression, that impulsive behavior, high risk behaviors, maybe unprotected sex, so some STIs, substance or medication overdose, so death, there's a mortality risk here. And of course, the consequences will depend on the type of substance the client is using. Tobacco risk is going to be different than, let's say, narcotics and alcohol and so forth. Okay, well, very briefly, let's talk about etiology of substance use disorders. And the first one on the list is the sociocultural factors. I know we have talked about this concept before with some other mental health issues because they do overlap. It's a very similar concept. We believe there are multifactorial reasons for these issues. It's not just one factor. With the socio-cultural factors, we believe the overall environment plays very important role. So think of a situation when you have a client growing up in poverty. Let's say you have a child in a poor neighborhood, if you will, poor family who lives in what type of a neighborhood they're going to have. Poor resources. I hope you understand that when you're growing up in a disadvantaged neighborhood, what type of resources these clients are going to have? Well, poor, right? So if you have a disadvantaged neighborhood, what type of support system this child will get growing up? Poor, right? If you have a child who's struggling, some kind of stress, let's say, I'm not even talking about mental health disorders. I'm just talking about, growing up with some kind of stress, trauma, maybe, I don't know. What type of support system this child will get, or society has to offer in a poor neighborhood? Well, poor, right? What type of coping mechanism do you think this child will develop? Healthy or maladaptive? I hope you agree with me, it's going to be a maladaptive. Why? Well, think about it. If you live in a neighborhood where you have easy access to either alcohol or tobacco or any other substance as compared to access to counseling, then what type of coping mechanism would you expect from that individual? Poor. And you can drive through any type of a neighborhood, by the way. It doesn't even have to be a poor neighborhood, but any neighborhood in our community, you will see that we have more and easy access to some kind of substance or multiple type of substances instead of access to a counseling office. If you are lucky enough to have insurance that cover all those appointments, try calling them and tell me when was the earliest appointment available. It's not going to be tomorrow. It's not going to be day after tomorrow. You will be lucky if they're able to see you in 6 weeks or 8 weeks. But you're having a bad day right now, today, and you need help today. What do? You get access to alcohol or tobacco. I am not really trying to justify that behavior, by the way, and I don't want to get into politics either. That's not the scope of this lecture at all. But my job is to really present these barriers, if you will, right? This is for educational purpose only. So I think as a clinicians, we need to understand those barriers and understand why this client chose this option versus making an appointment to see somebody who's a professional. All right, so what happens when they end up using that substance, and what if that substance is actually illegal? Well, they're going to have poor consequences. That means trouble with the law, and now the cycle continues, unfortunately. Now they're more stressful and they don't have access or not easy access, and the cycle continues. Okay, the second point here is the psychological factors. One could argue that how is it possible that two, family members, maybe siblings or brothers or two friends who were raised in a similar sociocultural background, one is running a drug rehab clinic and the other one end up using a drug and is a client in that rehab center. How is that possible if everything has to do with the sociocultural factors? Well, that's when we say it's a multifactorial, right? So even though two people are being raised in the same environment, we know it's not literally the same environment. We know that even as siblings, if you have 4 kids, they are not being raised the same way. You think they're being raised in the same environment, but it's not. Every individual perceive the same environment a little bit differently, and they may have some other underlying things that you and I are not aware of, such as maybe some kind of abuse, either physical or sexual, a different type of stress or trauma, or some other underlying health issues. So even though it's the same environment, you may have different outcomes. And that brings us to a next point, is the genetics. And we know that there are certain things that tends to run in the family, right? And substance use disorder is also one of them. And there's also dopamine theory, and we're going to talk about that next in detail, okay? Okay, so I want you to focus on this area called nucleus accumbens. This is the area which is a part of your ventral stratum area. This is responsible for brain's reward center. Okay, so and overall we'll call this a reward circuit or center. And the reward comes from the fact that this area release a dopamine, a neurotransmitter called dopamine, that helps with motivation, pleasure, and the same dopamine, when it's found in frontal cortex, will help with the decision-making process, create some activities to work towards a goal, personal objectives, and so forth, right? It really helps us find a meaning and purpose in what we do in life. And that's a good thing, right? We keep doing things because we feel good. We get pleasure out of that. So that's a good thing, right? And altogether we call that like a limbic system, if you will, right? And so you can say that a limbic system in the setting of dopamine play a very important role when we talk about a reward or pleasure. Now, what happened is drugs actually work on a nucleus accumbens area, where they will trigger this area to release more dopamine in the mesolimbic pathway. Now, and when you're releasing more dopamine, you feel good, you're getting more pleasure, and this will reinforce that drug-seeking behavior, and this dysregulation will lead to craving and keep using the same drug over and over again, right? So you can say that the drugs, they hijack our brain, right? And we keep doing the same thing over and over again, even though we know that at the end it's a bad thing. Now, we do not measure dopamine as outpatient or in a routine clinical settings, if you will, but we can measure, and we do, if you're studying a drug or in lab for research purposes and so forth. So depending on the setting, the units can vary, especially if where are we measuring the dopamine from? Is it in the blood or CSF, cerebrospinal fluid, or urine? The units can be either a picogram per milliliter or microgram and so forth. But let's say that I'm going to just give you a silly example. Let's say that the baseline dopamine measurement in the urine, let's say, was 100. We'll keep it simple. 100, let's say, I don't know, we can say a microgram per a day, in one day, right? So if you used either alcohol or some other drugs, the overall release of a dopamine is going to be maybe 200% more. So now you're feeling 200% better, right? And that's going to be your new baseline, if you will. Why would you ever feel 200% less tomorrow? Why would you ever do that? So that tells you how critical the role these drugs play in hijacking our brain. So I think earlier when I talk about do not judge people and have a better understanding of a pathophysiology, I think this is what I was talking about, and this is important education I think that we should give early on in elementary school and a child, adolescent, so that they really understand how dangerous these drugs can be. Okay, with that understanding, now I'm really gonna set the stage for our DSM criteria for these substance use disorders, and there are 10 different classes of substance related disorders, and they are not arranged based on what is the most common and then second most common and so forth. They're actually arranged alphabetically from A through Z, if you will. And the last one here on the list is your non-substance. 1 through 10 is a substance use, and then the last one, there's just one item here, at least for now, is a gambling disorder. That's a non-substance. But the overall pathophysiology is pretty much the same or similar, I should say. Now, 1 through 10, number 1 here on the list is actually alcohol, which happens to be the most commonly used psychoactive substance worldwide. And the second most commonly used psychoactive is actually caffeine, as they just happen to be listed as appropriately, even though they were listed alphabetically, if you will. And the third most common used substance is actually number 9, which is tobacco use disorder. And we're going to talk about these items one at a time in depth in second part, second and third, and we'll revisit this slide again, okay? Now, what I did on this slide is I actually grouped those 10 substances together as a broad category, if you will, and you have 3 different classifications. The first one is a stimulant. So any agent that will stimulate our brain or brain neurotransmitters, they will fall under this category. So when you are using a stimulant, you expect increase alertness, right? You feel more alert. And if it's too much, that can lead to anxiety, aggression, and so forth, right? Now, in the middle is hallucinogens. This is where you may have a substance that can cause either visual or auditory hallucination. So there's a change of sensory perception. And it doesn't have to be auditory or visual. I mean, we have seen, smell, olfactory, and tactile. Like with alcohol, people will report tactile hallucination. They feel like bugs are crawling on them. Cocaine can do the same thing. All right, so you have examples in front of you. How about a depressant? Depressant is going to be the opposite of stimulant. This is where we are going to depress or decrease CNS function, and you have examples such as marijuana, alcohol, narcotics or opioids, I should say, and benzodiazepine. It's going to slow down the overall process, if you will. Okay, so it's a good slide to really keep those agents in broad categories, if you will. Okay, well, this is a very generic slide that I created just to summarize what we just talked about, that in general, the stimulating agents are more likely to cause substance-induced psychotic disorder to stimulate more, right? So like anxiety and so forth during intoxication, when you have too much. On any given day, when we talk about these disorders, I want you to think of 2 things. Either the client is using the drug, so that's substance use disorder, and then you have intoxication, or the client is going through withdrawal, right? So those are the presentation that we need to understand, because that's what we see from the clinical standpoint of view. So if the agent falls under stimulating category, then during intoxication you will see more anxiety, psychotic features, and during withdrawal it's going to be opposite. You will see more depressive episode. Now with the sedating agents, during intoxication you will see more depressive disorder, and during withdrawal you're going to see anxiety. So it's going to be the opposite of each other, right? Now on any given day, in any given setting, both the more sedating and more stimulating agents are likely to produce a significant but temporary sleep and sexual disturbances that can occur with both of these agents. Okay, next I want to introduce a concept of a dual diagnosis. I think it's very, very important to have appropriate diagnosis. The term dual means two, and that does not mean that any two diagnoses, by the way. When we talk about a dual diagnosis, one of them is substance use disorder, any type of substance, at least one has to be substance use, and then the second is at least one mental health disorder. Let me give you an example. Maybe you have a client with alcohol use disorder, and so it's and, not or, okay, and some other mental health disorder, maybe ADHD or depression or anxiety or bipolar, schizophrenia. So you can have more than one though, but you need at least one. And same here, you need at least one substance use disorder, but you can have more than one, right? You can have alcohol and tobacco, or cocaine and alcohol, and so forth. What you cannot have is just two substance use disorder and call that dual. No, that's not a dual. That's still a substance use disorder. And you cannot have just two mental health disorders and call that dual. Those are two mental health disorders, okay? That would be a comorbidity. But when you have one of each, at least one of each, you can have more than one, by the way, then we'll call that a dual. And why is that important? Well, these individuals are at higher risk. These are complex disorders to treat, and they're usually assigned to a special program, clinicians who are trained to treat these issues. And so I think it's very, very important to give them correct diagnosis. Okay, what is the treatment principle? This is very like a general slide, generic. We are going to talk about treatment options in depth in part 2 and 3 based on the individual agents. But overall, I think the treatment approach is number one, that this is a chronic disorder, okay? So just like the way we treat diabetes, right, or some other chronic health issues. So I want you to think of substance use disorder as a chronic disorder, and the approach should be multi-dimensional. It's not just one person running the entire show. We need other clinicians, a therapist and an individual who has a special training in substance use disorders and so forth, and PCP and some other IDT members, if you will, right? And then we really need to determine the level of care this individual need. And level of care really depends on when you're going to identify this individual. Maybe it's from outpatient standpoint of view, with early interventions, maybe a child in elementary school perhaps, or high school. So anyways, the focus should be early intervention, and then if possible treat as outpatient. But sometimes just it really depends when you had a first encounter with the patient. Maybe it's too late, or maybe it's the symptoms are very aggressive, and then you need to treat them as inpatient. So that would be intensive care. And the intensive care can also be, by the way, in outpatient or inpatient. So there are partial hospital programs, residential services, rehab clinics, and so forth, both outpatient and inpatient. The primary goal has to be very clear, and the patient needs to be on board with this, right? So are we trying to achieve complete abstinence, if you will, right? And the answer should be yes, that should be the overall goal. But perhaps today, and maybe if it's outpatient, the short-term goal may be to decrease the amount of use, right? So for example, if it's early intervention or maybe outpatient, and you have a client who smokes, I don't know, maybe 10 cigarettes a day, let's say, and then maybe today the goal is to decrease to 8 and 5, and so slowly taper them off, right? Same principle can apply with a benzodiazepine or some other, maybe alcohol and so forth. So I think it's important to understand the overall goal, and maybe the goal is to prevent relapse, right? But I believe the primary goal, we should aim for is to quit taking that drug or that substance altogether. Okay, well, it doesn't matter if it's an outpatient or inpatient. There's a clear role for non-pharmacological interventions. I think there's enough evidence, and these are wonderful options along with pharmacological interventions. And we'll talk more about medications in our second and third part. But here I just want to introduce some of the options that we have from a non-pharmacological intervention standpoint of view. The first one on the list is CBT. And I think by now we are very much familiar with this concept. This is when we focus on the maladaptive behavior, right? The way we think and then the way we act on it, right? So the focus is going to be on to identify those issues so that we can reverse those habits. Anything that promotes drug use, we're going to reverse that, right? And the first thing is to identify. And how do we identify? Well, number one, what is causing? What's the root cause of this? Do that analysis. So usually it's a stress, or are you hanging out with a wrong crowd, if you will, right? And we know the concept of peer pressure, right? So identify that, develop some healthy coping skills, and in this case, if it's a wrong crowd, replace that with a more appropriate friend circle. Stop talking to those people who always call you in their backyard or in the garage. Instead of doing that, maybe go with a friend or cousin who enjoy going out for lunch, or watch a movie, or go out for ice cream and so forth, right? And so anyways, it's really highly individualized therapy, and it's very we have enough evidence it actually works very well. Okay, so next is a family therapy or marital counseling. We know that the substance use disorder, of course it has effect on that individual, but it's beyond that, right? The entire family is going to unfortunately suffer, or is going to be involved somehow, even if they live together or not, right? So we can offer that type of a therapy to the entire family, when to identify, or how to identify those triggers, how to intervene, how to talk to these people, and when to ask for help, and so forth, right? How to deal with that while they are recovering through these going through these interventions and recovering from these symptoms, and not enable their behavior. If, for example, during family therapy, we talk about a concept that if your loved one was drinking all night long, and this morning they're sick and they have a hangover, and they're asking you to call their supervisor that, hey, we have a family emergency, and then my spouse or significant other or my child was not able to come to work, don't do it. put that responsibility back where it belongs. So otherwise you're encouraging that bad behavior. You say, no, I want you to call your supervisor, let them know that you were drinking last night, and therefore I cannot come. Be honest. People do that. People call on their behalf, on their loved ones, out of love, right? But that's not a right thing to do, by the way. Put that responsibility back where it belongs and hold them accountable. Yes, they will be embarrassed, and of course, and that's the whole point, to learn from those mistakes, right? Anyways, so that's just one strategy. Group therapy, I think it's very, very important. We have a lot of evidence on that. I think people learn from their peers when we know that I'm not the only one with that concern. There are other people, and we want to learn how they handle those issues, what works best for them, and we want to try that. In my practice, we do offer a group therapy, and we try our best to group them together with the similar issues. For example, if it's alcohol, or I don't know, let's say bipolar, or schizophrenia, if it's a medical management, or whatever that similarity is within that group. Okay, next is your self-help groups. I think we all know the importance of that, that 12-step program for alcohol or narcotics or cocaine. We'll talk more about that briefly, in part two, but we have enough evidence again for this type of intervention. Okay, next option under non-pharmacological intervention is your motivational interviewing. This is a concept where you have a client who is going to be the center of this approach. Of course, it's a patient-centered counseling where we ask open-ended questions and reflective listening. The idea is to really promote change here, right? Behavior change, and we express empathy, and we use a therapeutic relationship to support their overall experience and behavior. Now, for example, if the patient tells you, I know I should stop drinking, but it's the only way I relax. So that's a statement. Remember, this is a patient-centered counseling. Clinician will use reflective listening and make a statement. It sounds like alcohol helps you cope with the stress, but you're also worried about its impact on your health. So this shows that you were actively listening. If you're able to actually paraphrase their statement, that gives them a message that you were listening. If you are not listening and paying attention, then you won't be able to paraphrase, right, and ask appropriate question or summarize their issue. And then you're going to offer that like open-ended question, if you will. Never use a closed-ended question with a yes or no response, right? It has to be open-ended. That's a therapeutic relationship. So what changes, if any, would you like to make in your drinking habit? Instead of saying, are you ready for a change? Would you like to make any changes? The answer is no. If the patient says no, then you're done, right? You locked yourself. So never ask closed-ended questions. So this is just one strategy, if you will. It works for a lot of clients, and we do have some other options. And this is one of my favorite non-pharmacological interventions, if you will. Contingency management focus on a specific behavior and consequences out of that behavior. In other words, you identify an appropriate behavior that you would like to see, and it's a collaborative approach, of course, between the clinician and the client. And once you meet that expectation, you get reward, and you do not get anything if you do not meet that expectation. So it's all based on of a consequence of that behavior, right? So remember, we started our story with that reward pathway, if you will, right? We said that we get pleasure, and then these substance will hijack your brain, and then it's all a part of the reward pathway, and that's what we want to focus on. We want to just replace that maladaptive with a healthy coping skill. So and I use that a lot, by the way, in my practice. So what we tell our patients is, well, first of all, you can either have a short-term goal or long-term goal, and we do both. Long-term goal is going to be that I'm going to discharge my patient back to the community, right? That all of my patients, they ask this question: when can I go home, right? And the answer is, well, it depends. It depends on you. Depends on what? Depends on your overall behavior in the unit. Depends on do you attend those program groups, right? Group therapy, individual sessions, medication compliance, overall behavior with the peers and with the staff, any physical altercations, verbal altercations, and so forth, right? So we set those goals and they work towards that. And if they are meeting their criteria, then they're making progress, right? So when you set up those short-term goals, we give them a reward like a voucher or something, some kind of privilege. What we do is when we arrange like outing, they can go out in a park, or maybe I don't know, for shopping, or dollar store or something like that. They have to show that they were at their best behavior, if you will, for the past 1 week from the previous outing or previous encounter. So when I make rounds, the patient tells me, oh, can I go for outing? Can I get a pass for shopping and so forth? And so my question to the nursing staff is, how is the patient doing overall since I saw the patient last? And if there was any behavior issue, if they refused medication or they had some physical altercations, and then we'll tell them, no, you cannot go because of blank, whatever that issue was. And they understand that, and we are very firm with that, by the way. We do not make exceptions. We don't want to be like, we're being nice to them in a way that we're holding them accountable. So you don't want to be super nice and keep making exceptions. It's a learned behavior, right? So we'll say, well, make sure you follow that protocol, and next time when we go out, we'll put your name down for next time. So those are some options we give. The example here is if for like outpatient, if the patient gives you a clean urine sample every single time they come in, they get a voucher for groceries, let's say, and so forth. So take a look at these. I think these are wonderful interventions. And by the way, you can use contingency management approach in any given setting, in multiple settings. It doesn't have to be for substance use, by the way. It can be for other mental health issues like a conduct disorder in adolescent population, medical management, medication management, not just in substance use, but in other chronic issues like diabetes, HIV, and weight loss program, and so forth. Okay, so I just wanted to make a point here that even though you can always use one a type of a psychotherapy modality as a monotherapy, but I personally believe it's always a good idea to combine a few modalities. At least that's what I do. You take few pieces here and there and come up with your own recipe, if you will. For example, with contingency management, even though technically, speaking, you can use as a standalone monotherapy, but what I believe is that remember with contingency management, we are asking them to be in compliance with whatever the objectives are, and then we give them a reward, right? But we also need to help them to get there, right? And that helps come from perhaps from CBT, when we ask them to identify those maladaptive behavior and replace them with the coping skills, and perhaps use a motivational interview to really challenge them and identify those barriers or those triggers, and plus minus use pharmacotherapy to really minimize the that overall impact from those disorders. The point I'm trying to make here is that you may have a client where just a CBT might work, right? Or just a pharmacotherapy might be a good option. But when we sit down with the patient and we develop an individualized plan, I think we should consider a comprehensive treatment plan so that we get optimal outcomes. So it's always a good idea to use multiple modalities together, even though you can use one modality as a monotherapy. Okay, well, so far we talked about a basic concept of substance use disorder. We talked about some definitions, etiology, pathophysiology, and then we really focused on psychotherapy, non-pharmacological interventions. Let's take a quick bio break. When we come back in part 2, we'll focus more on medical management. See you then.